interesting how they can be live with several shows. There we go.
Yeah. There we go. Get rid of the ugly clinic.
Hey Mo. Hey Mo.
Hey, Ricky.
How are you?
I am just well. I'm wonderful, magical. I'm excited. It is Woosah Wellness Wednesday. The doctor is in.
The doctor is in, and we're twins today with our when we
We're
talk.
twins.
Yay!
I love it. It was
We
so
have to
nice
get
to
these
get the package.
I know we have to get with the program, Sarah.
I know.
I know. I feel underdressed.
I know. We'll have to get you a hookup. But we have a great show today. You know, we are on our clinical trials parade for the month of May, getting ready for International Clinical Trials Day, which we're making a national holiday for the whole world, right? But we have some incredible science sheroes who are advancing the science for breast cancer and doing amazing work. You know, we have our Dr. Sarah, who's on our medical advisory board, who's been here before. So thank you, Dr. Sarah. And we have Dr. Laura Esserman, who is a fierce badass in this space, doing amazing work. So I'm so excited to talk about what they're doing and just really all the great things they're doing to help with screening, to help with the science, to help with, you know, new therapies and like just help us save the world. So we're so glad you're here.
One breast at a time.
That's right. You know, I can't tell you the number of patients who are asking the question about what screening do they need? Is it right for me? How do I know? What about my family history? What about my risk? And they want more. They feel like in 2022, you know, year of our Lord, we should have more options, more tailored options, and we should be looking to the evolution of what breast cancer screening looks like. And finally, you guys are asking and beginning to answer this question. So we're thrilled to have you here today. I mean, your reputations just precede you, your research with I Spy, Dr. Esserman. So thanks for joining us today.
Oh, well, thanks for having us. We're excited to be here. Anything for Ricky. She's awesome and fierce as well.
No, thank you so much.
So thanks again for asking us to be part of it.
Yeah. So why don't you go first and give us like your version of what you do, because we could talk for 3 hours.
And why?
Okay.
Give us your why.
I consider myself really, I'm a fierce advocate for my patients. You know, my goal is to do something better tomorrow than I'm doing today. And the work isn't done until I sit across from someone and they say, wow, I love all those options. That is great. I'll do that. That has not yet happened for me. So, you know, I've really trying to think about, you know, and asking the why. Why are we, you know, if we're doing things the same, why are we doing them the same? Are you sure we can't do it better? I can kind of tell you sort of I give you kind of the spectrum of things that I'm working on. So, you know, again, I can tell you, you know, when I first started practice way back, you know, I trained in the 80s, okay, and there were hardly any women in surgery. And I mean, back in the day that I trained the era when radical mastectomies were done. I trained when women were rolled off to the operating room. They had a biopsy, and if it was cancer, they had a radical mastectomy. No choice, no options. And even when things started to change and they had switched to modified radical mastectomies, care was fragmented, people weren't given choices, everyone got the same thing, chemotherapy, if they had a tumor that was centimeter, we thought breast cancer was the same thing. And I thought, wow, this is, you know, we need a lot more science. You know, I was just like you, we need trials, we need a lot more science. Women are left behind. No one's paying attention to these issues. And I wanted to build an integrated clinical program where people could come and get care and be partners in their decision-making with an eye towards making sure that we were asking the questions to try and make things better, to say, how can we improve? How can we make things better tomorrow than they are today at every step of the way? Quality improvement, change for the better. That's really what clinical trials are. I mean, care should be that way. Trials should be that way. And trials are just a special way of saying, let's test tomorrow's treatments today. And a lot of people say, well, why do it?
I love that. I love that. I love that. I'm stealing that line. Okay.
Yeah, we'll quote you on when we trial. Let's test tomorrow's treatments today.
And the thing is, every good idea isn't going to work. That's why you have to test it.
Right.
And, you know, if someone says, oh, I'm going to do this, have you tested it? Do you know? And if they haven't, that's probably not good enough. And why do I care about trials? Because if I do something that works for one person, I've helped that one person. But if I do it in a way that helps in a trial that everyone can see, we change the world. Everyone can move along. And, not everyone likes change. It took a long time to get change.
Yeah.
It wasn't the physicians that were pushing breast conservation. It was the women.
Yeah.
Women
Right.
in droves went.
Right.
And in fact, one of the trials, I'm trying to look at for DCIS, active surveillance options or vaccine options. The physicians are signing up in droves for it. Patients are coming from all over the world for me to do nothing. It's people, I have been influenced from the get-go by my patients, by their stories, their experiences, what they hated, what made it better for them. That's what drives me. And I had, one of the first people I took care of was a young woman who grew up in Harlem. Her name was Linnea Stevens. And she was the first in her family to go to college. She was a graduate student in sociology at Berkeley. She had triple negative breast cancer when she was 31. And she was just this amazing, vibrant person who, you just couldn't help but fall in love with, right? And, she had a family that loved her, mother, grandmother, friends, fierce Scrabble player, amazing, but like her dreams did not come true because she died before her 30th birthday. And, I say to her, that was one of the things that made me start the I Spy trial. I thought, oh my God, we did not have the right drug at the right time for her. That was not good enough. And like saying we're following the standard of care, what does that mean? The standard of care, she died because of the standard of care. And I think a lot of us know 10 Linneas. There are hundreds, thousands.
Can you explain that? Can you just explain that a little bit when you say she died of standard care? Because we're trying to make that concept, you kind of really articulate what that means to people. So can you just explain that a little bit?
We gave her what we thought was the best care. She had adriamycin and cytoxan. We thought that was the standard of care at the time.
Which I took and didn't work for me either for TNBC.
Right. And it did not work. Right. And I operated on her. We then gave her treatment, hoping everything was for the best, which it was until it came back. That's too late. And I said, I'm not going to do that anymore. You're fooling yourself. As a surgeon, I'm a surgeon. I would love to say, oh, let me do this. I'll operate on you and make it all go away. That is not going to do the trick. I'd
Doesn't
love
work
to be
that
the
way,
hero,
does
but
it?
I'm not.
Yep.
I am a breast cancer advocate. I have to say, I want to use my craft wisely. So what we decided to do was flip the order of therapy. I was very lucky. One of my dearest friends, who at the time I first met when I got here, Nola Hilton, was doing her postdoctoral fellowship. She's a PhD in physics and was writing the sequences for what became breast MRI. And she came to me and said, how would you use this? I said, I want to see the people who show up with these bigger cancers and see what those cancers look like. And lo and behold, they didn't look the same. And then I said, let's treat people first. If the treatments are going to work, they're just as likely to work first, and we can see. And lo and behold, some people responded and some people didn't. And you have to look at that and say, everyone shouldn't be treated the same. And today we now know this. With trials like I Spy, it became the standard of care. We've tested 27 combinations and figured things out. We have taken, the trick is to treat until the tumor goes away. That complete response rate has gone from 20% to 60% in these 12 years by doing it this way. We've tripled the chance that someone could survive. But we don't have the solutions for everyone. We have much better treatments for people like Linnea. And maybe today she wouldn't have had to die. And by the way, we're not done. Now we're starting our next phase. We're not done until everyone has a non-toxic therapy that works. Then we're done.
Love
Just because you have one success, you don't stop. So like we're now saying, well, look, there are all these cool new drugs that are these antibody drug conjugates, or it's like a homing device with a little bomb in the knapsack, so you send it to the tumor and hopefully it'll explode and get rid of the tumor, or you can harness the immune system. There are all these cool ideas. Put them to the test. Give them their day in court first before you give all the other toxic stuff that people hate. my goal is to get rid of some of that and
Yeah.
but figure out for whom it works, because there's a bunch of people for whom it doesn't work. And, we were just saying this the other day. I said, okay, we'll give the new things and then we'll give the backup is the standard of care, right? The best that's working.
Right.
And we had a call the other day and they said, well, and I said, well, for this one type, this luminal B type of cancer, which by the way, is probably what I think is leading to that increased mortality rate for African-American women. And people said, oh, but you're not giving the standard of care. I said, well, they have the choice. They either get the tax, oh, they get something better or different, not necessarily, but and they said, well, that's not standard. I said, okay, well, how are we doing here? Not very well. This is the group for whom we don't know how to treat. Why are we not asking the question, how do we make it better? If you don't try something new, you can't possibly expect a better result. We
Thank
have
you.
to try,
We have to
right?
try.
We
When we
have to
trial, we have to
we try,
Yeah.
right? And so I I'm not going to apologize. Some people think that I'm going too fast or try. In I Spy, we're very lucky. The patients in our trial pretty much reflect who's in the population. So 12% of our patients are African-American. And I'd like it a little higher, but I'm pretty happy with that. And Sarah can talk about how we're going to make it higher.
And way more than any other trial we know about. Can you just
True.
explain I Spy a little bit for our audience?
Yes. So I Spy is this idea of how do you get the right patient to the right drug? So we used to randomize people to, either your backbone of Taxol followed by AC and adding agents. Now we're trying to figure out how to personalize that therapy for each person. Start with some of those new targeted therapies up front. If you get a complete response, you can go to the OR. If you don't, you go on to the thing that we think is best, tumor targeted therapy. What is best for you? So this is a trial where we are testing new drugs, but we're individualizing therapy. In the trial, each person gets 3 shots on goal. And only if if the second thing doesn't work, would you get to AC, so it's like, it's a model that you can keep learning and improving. We're constantly changing. And because we've had, over 2,000 women in this trial, it's a living, breathing, dynamic thing where we're constantly learning, constantly improving. It's open 35 sites around the country. Sarah can talk about our plans for trying to figure out how to make sure it's accessible. But why is this so important? Because we are testing some of these new immune drugs for people with triple negative cancers. And it turns out that it's not just triple negative breast cancers.
Right, that's right.
If you're hormone positive, 1/3 of those high-risk cancers are going to be just like those triple negative breast cancers. And they behave just the same and they should get those same drugs. And so it is so important. It is so important for
I gotta
women.
highlight a couple things you said, though. You just said some really key things. And the first thing that you said is that not everything that comes through a trial is going to work, right? But everything that works came through a trial.
That's
And I think
Hello,
that's
hello.
something that people need to know. And we're going to put that in the chat. The second
Yeah.
thing you said is that people are coming to you now for nothing, for no surgery, right? And this is
Well, that's
different because-
DCIS. That's for DCIS.
for the
This is different.
DCIS
This is
trial,
high-
exactly. But people always think that a clinical trial involves doing the most. It
Right.
involves doing toxic things. It involves all the, they tend to think that it's so much more extreme, and maybe doing no surgery, it could be perceived that way, but patients don't
But it's not.
necessarily. It's not,
we're-
exactly.
But we're
Right.
trying to figure out how we can do less
Yes.
safely.
Exactly.
That's
And
so
that's
important.
huge. And I think people need to know that trials are not always toxic drugs. They're not always the most aggressive surgeries. They're not, it's a really individualized and a really
That's-
specialized way of looking at their disease and at their tumor,
And importantly, if your tumor goes away,
Mhm.
you don't need a mastectomy, or you don't need to have something big and radical.
And the
You can
third
have
thing-
something less. That is tailored to you.
To
Mhm.
you.
Tailored to you. And the
Tailored
third
to
thing I heard
you.
you say was that the standard of care changes based on what we know and based on these trials. It's the best thing we know at the time, but even the standard does change. It moves based on the new information that we get. And I think that's something that patients don't understand either. They think that the thing they've always gotten is the thing they're always going to get, but it's this research, it's these trials that inform what
Right.
that standard of care is going to be, right, Doc?
And I'll tell you, we studied African-American women and we found that they have just as good a chance of responding to these new immune drugs, which triple the chance of a good response. So it
Right.
means that African-American women have to get the standard of care. They shouldn't shirk it. But another thing we found that seems to be coming up is that if you have hormone positive disease and you don't get to a complete response, those people do worse. If you're African-American, you do worse. And we're trying to come up with better treatments for that group of people.
Say that again. Say that again for Black women.
So if you have a hormone receptor positive tumor that's aggressive and you don't get a complete response, you're not going to do as well. And we've got to learn why that is. We have to know, because knowledge is power.
Yeah.
All of these things that we're learning, we're finding we're going to bring in a new drug that might work. We're not going to give just Taxol. We're going to test Taxol against something better. And the minute we know it works, we can slide that into the standard. But if you want it to be better, you gotta, I always say that, if people don't participate, they won't be represented. And no representation, we can't tell. I had to write a commentary about the new metastatic treatments, with one of the cyclin inhibitors. 2.5% of the population in that trial in the New England Journal were African-American.
Yeah.
And the hormone positive. Does that drug work for you guys? I don't know.
Right.
And that,
we cannot do that. We cannot do that.
right. And that's the importance of the initiatives that are coming out of Quantum Leap now. And, specifically with I Spy, as well as Wisdom. I mean, everything Laura said is what attracted me to Quantum Leap. But as she talks about how we learned about these new drugs and how they work in people, again, historically, that has been without the participation of African-American women. Like Laura just mentioned, most of the time, the participation is in the single digits. And
we know that, and we know, Sarah, even if you look back in 20 years ago, when adriamycin and Cytoxan and Taxol were all made, there were no Black women in those trials.
Right. I mean, even back,
Yeah.
earlier, there are even fewer, but so that's why I Spy is unique. It has one of the few trials that is reflecting our community and more by having it, double digits as African-American participants, as well as other underrepresented, minority groups. And part of that is because of the dedication to try to get these patients
Right.
on the study, which is not always the case. And I saw that when I was at FDA, when I would look at the studies and you'd look at the sites and you would see there was no motivation for a pharma to do anything but just go to sites that are going to, populate their studies very quickly. And unfortunately, that tended not to be our communities and our institutions that have these patients. So one of the things that we're working on in I Spy, despite these great numbers already, and knowing the importance of this study because of the information that's being gathered. I mean, there's genomic information that's being gathered. There's, determinants of health information that's going to help prospectively help us look at what's going on with these women to see if these variables, how important they are in their outcomes. And so, so we're looking at targeting at least 5 institutions that, and by institutions, it could be a community center, it could be a university, an HBCU, but a place that sees cancer patients with primarily minority and underrepresented patients, as well as hopefully investigators of color to be involved in the leadership of getting this study done and getting our patients on the study, because as Laura was saying, it's an amazing, innovative, beautiful study in what we're looking at, but it's complicated. And so getting a site to be involved is going to be, it takes a lift even from institutions that do research all the time. So, to make this commitment, for Laura to say Quantum is going to help, support the places that need community oncology like in rural areas in Tennessee, there's some, the HBCU, I worked years, I still work at Howard, and I know how difficult even at a Mecca, can be getting research done, to put in what needs to be done, even though it might be a little bit more on the end of quantum leap, but the outcome is going to be so much more in terms of what we're going to find out and be able to look at. And we'd like to get that number up, to me, if we can get it to 20-30%.
Well, it's a
I'd love
particular
that.
reason why we could do that. And so again, this does not happen by accident. It happens by intention.
Yeah.
We're very intentional about this. And, it is, and it also is true that African-American women, 25% of the cancers, the breast cancers they develop are triple negative.
Yes.
And for white women, it's like 10 or 12%.
12%, exactly.
But you could flip it the other way around. We have just as good a response as the African-American women. African-American women have more of these cancers. The more we know about those cancers, the better it is for the white women who also happen to get it.
Right.
Right. So it's like, if you take away, and race is a social construct, by the way. It's not, ancestry is what you want to know. We have the capacity to look at it. Well, I'll get into that a little bit later, but it's like, a rising tide floats all boats, right? So if, so for
Right.
the white woman who shows up at 55 with a triple negative breast cancer, while that may be unusual, she still has it. If I was able to study this well, and I knew how it works, and I know the nuance of who's going to respond and who's not, I can give that white person, better care because I had more African-American women in the study. And, when we think about what people in Africa need, they have like 60 or 70% of their cancers are triple negative. They don't need the stuff that doesn't work from here.
Right,
They need the
right.
stuff that works for that biology.
Yeah.
That's our opportunity. And everybody learns best by doing it that way.
Yes.
And
Dr. Sarah, I love that you said that about, getting more research from the community hospitals. I'm a director of a cancer program in a community hospital, and we struggle to get some of the trials and to get patients involved in the research. But when you say 80% of, Black and brown women get their cancer care at community centers, we've got to do something different, because the same things we've been doing are not working to increase trial enrollment. And so I think it's really, innovative what you guys are doing in the way that you're looking at this from a different angle, rather than to continue to funnel efforts into sort of these trickle down studies. It just doesn't always happen that way. And it has to start from some groundswell and from the communities and from the community providers who are interested in bringing this to their institutions, but really have to be innovative and creative on how to do that with the resources that they have, which are so limited.
But it should be part of the treatment choices. Like, it shouldn't be like an afterthought. It should be, okay, here are all the things we can do for you. First of all, there's I-SPY, where we're going to give you targeted treatment for your disease. Like, it should be one of the things that you can choose from. It shouldn't have to be, oh yeah, here, take this TAC, whatever. Okay, and then if you want to be in a trial, we'll tell you about that next week. It should be, here are all the things that are best for your care today.
Yeah.
You should have the option to do that work, to do that for yourself right now. You know what I mean?
And I designed this trial as if my sister had it, or my best friend, or Linnea, that I want it to be better than the care today. It's not designed for a particular pharma. Now, we need them because they're making the drugs that we need, but it's not, it's designed
for the patient.
Centered, because that's, if we can make trials that, if someone says, well, what would you do? I said, I would go in the trial. The trial is better. I think it's got better options in it than what's the standard. That's the point. Now, but I'm putting it to the test. I'm constantly looking and trying to learn, right?
Mm.
So that's, I think, and the thing about it is, people, you have to be intentional about where you open trials like I-SPY, unlike Wisdom, which we're going to get to in a minute. And it is so critical for people to see physicians who look like them saying, I am part of this. I believe this. I trust this. That helps people trust it. And I know that, it's one thing for me to say it, but it's another, like, people want to see people who look like them saying, I trust this. This is important.
And you know what, Dr. Laura, what our research told us is they want to hear it from a breastie. that when you look at when we trial, everything we built it on was breasties talking to breasties, for breasties, about breasties, with breasties. And I think that's how I want to help you get this word out, because we can use our breastie community to bring this education to our patients.
All right, let me tell you another really important piece of information to know. And hopefully after this year, this will be the law of the land. There's lots of things we have to fix, but at least this is getting fixed. So in California, I helped Jackie Spear, who is then a state senator, write legislation that says if there's a trial that's open that you are eligible for, that you qualify to be part of, you can go to that institution and get your care there, and whoever covers your care has to pay for the standard of care costs at that institution. So if you're at like a place like Kaiser, doesn't have the trial open, and you could come to UCSF, be part of it, or like wherever it is. So that's the law of the land in California. Now, there are now 35 other states that have that, but we are working on making this national legislation. Actually, we should get a letter of support for you, Ricky. But this is something, if it's national, that means you can go to any one of the 35 sites where this is open, and hopefully soon 40, right, Sarah, that where this trial is open, but it's in but the law doesn't help you if you don't know about it.
Right. Well, we got to educate about it.
You got to exercise your right and say, I know this, and I can come to this site. I mean, I do it all the time, and I can say, here's SB 37, boom, and I have been known to call hospital directors and other places, and I said, really, do you want me to report you to the California Attorney General? Or the papers, this is like, I don't know who didn't get this information to you, but this is the law. I just sent it to you. It's in your email inbox.
Well, yeah, that's what we're trying to teach them to do.
And they're like, oh, really? But the thing is, you
have to ask for it.
You got to ask for it. You have to say, I want to be part of a trial.
Yeah.
You have to ask for it, because we're not getting asked. So that's what part of when we trial is also is you have to ask, you have to stand up, I was at an abortion rally with my daughter on Mother's Day. It's like, what do you do when you're not getting the right care? Show up and fight.
Right.
Cheer about it, but we have to ask for it. We have to position ourselves with the knowledge that so we can ask for it. That's part of it. What do I need to know?
Men have reproductive rights. Women, men have reproductive rights. Women need reproductive rights. No questions asked, no sex for anybody until the law has changed.
Exactly. No sex for anybody.
That's what I say.
If you trace where pregnancy comes from, there's a whole different conversation that we need to have about, about prevention, about contraception.
Right.
Exactly.
Right.
Stop the sex.
There's something necessary in order for fertilization to happen here, in humans. So there's some conversation we could have. Let me ask you this and switch gears a little bit. There's 3 doctors on this Zoom here. What do we need to do in medical education that's different, that can help to empower and inspire a generation of doctors to really dig into this at a time when they perhaps feel like it may either be an afterthought, or that the funding is drying up, or all the other things that we hear about cancer research that makes people not want to do it and not want to get involved? How do they get your passion, Dr. Laura? Dr. Sarah, how do they get their feet wet and apply for training grants and get the bug to carry on this work? What do we need to do?
Well, I run a post-baccalaureate program. So we take 15 kids a year before they go to medical school. This is like Dumbledore's army or whatever it is. And I teach about the importance of integrating care and research. What is research? What is clinical practice? I love what is clinical? What are we practicing for? We ought to be practicing to get better. But if you don't know what you're doing and you're not checking your outcomes, you shouldn't be practicing.
Right.
And
I love it. What are we practicing for? That's classic.
Right? You got to be better, and you have to ask the question. And part of one of the things that I'm super passionate about is creating the infrastructure so that you can learn what you're doing. Honestly, the reason we've been able to make strides in I-SPY is by switching the order of therapy, people could see what was working and what wasn't working. It's hard to look at it and say, wow, this isn't working. I feel bad. Oh, you feel bad? Great. Then you're not going to be afraid to try something new, are you? Okay. So it's like, and you know what? We picked fortunately some drugs have worked, but a bunch of them haven't. And it's like, I wish everything we tried worked, but everything doesn't work. But you've got to try, you have to think about who's on the other end of that. And I think you have to, in order to motivate people to change, you have to be brutally honest with how good your treatment is. If you think what you're doing is great, you're not going to be that motivated to change. But like, ask someone who's on AC how they're feeling.
It sucks.
Someone who's got neuropathy and lost their hair on
It
textile.
sucks.
How's it going for you?
Yeah.
Right?
Exactly, exactly.
And it's
Yep.
hard to want to walk home and say, gosh, let me just do the same thing tomorrow.
Well,
It's
insanity is doing the same thing over and over again, getting the same bad result. We're all insane right now. We're living in an insane world
what I
because,
always say. Get that,
right.
everyone has to be saying, when I
What's the
started,
new iPhone?
when I started the wisdom study, I made this pitch to the Robert Wood Johnson Foundation. And I said, all women demand the iPhone 8. Of course, now we're in like 16 or something like that. But
Right.
anyway, but it is like, and I still haven't finished that first enrollment. So it is, but part of it is the demand has to be there. Women, I think it's pretty clear from seeing what's going on in the country. No one's standing up for us. We have to stand up for ourselves and
Thank you.
insist
Thank you.
things have to be better tomorrow than they are today. And the only way to do that is to make sure we know what we're doing and that we're constantly trying to improve. The word about trials is not that they're like for guinea pigs or they're this or they're like, no, they are tomorrow's treatments today. Everyone should want to say, what clinical trials am I eligible for? What is out there that might be good? I mean, you don't have to do it, but you have to learn about it. And
Right.
that should be everybody's mantra. I want to know what I can do that's better.
Right.
And I want to be part of this because I have daughters or I have sisters or I have a mother or I have close friends and I care about myself and I care about my community.
But I love your analogies too. I often say, we automatically get in our car every day and turn on the key, put the gas on and go, knowing that the brakes are going to work, that the steering's going to go work, that the windows are going to come down, that the air conditioner is going to come on. And it's science. What's the difference? It's science. And the next new Mercedes that comes out, you're going to aspire to buy that one, right? Because maybe something is faster. Maybe there's not a CD player anymore. It's a digital thing. But there's an improvement every year that you aspire to have.
Yes, that's exactly right, Ricky.
Absolutely.
Aspire to better. Aspire to
be better, right?
And your healthcare providers.
You want the new Louis bag. You want the new shoes. You want the new whatever. You want the new whatever nail polish, right? So what's the difference? Get the best drug. You want the new drug. What's the difference?
This matters. Your life depends on it. So let's talk
Right.
about
Sarah, talk
let's
about
talk
that
screening for a minute. Let's talk about screening. And we're going to talk about that Mary J. Blige commercial.
Okay. I know you go with that. All right.
Okay.
That just crossed. Okay.
So
So
talk about it because I must have missed it. What did I miss here?
okay. All right. So let's go back to Linnea. Maybe today she wouldn't have to die because we have the right drug for her, right? But guess what? We didn't have the right screen for her either. She was in her 30s. How did we know she was at high risk?
Right. How'd she know?
And what are we doing today? Same damn thing we did in 1985, right? What
Nothing.
is wrong with us? Okay, so all I'm saying is we now know that breast cancer isn't one disease. We also know that, people aren't at risk for the same disease. Why are we screening every woman the same? Why is that? And, honestly, you would think because I criticized, it's not that I'm criticizing, I'm just being honest. 42,000 women died of breast cancer last year. And African-American women died at the highest rates, despite screening today. So to say that, oh, I go get my mammogram, I've done everything I can do. We're done. We are not done.
We're not done.
And that's what that
Not even
commercial
close.
was, that Mary J. Blige is on the table and this is the Super Bowl commercial.
Right.
And they come in and they say, everything's all clear. See you again next year. She goes, oh, phew. Like, again, the message is just go in for your mammogram every year. Everything's going to be fine. Okay. So here's what
Swing
I
and
know.
a miss, Dr. Laura. Swing and a miss.
So in I Spy, the majority of those cancers are not found with screening. Either women are too young or they're fast growing and they're interval cancers and they found between screenings.
Exactly.
Every woman needs to know if you feel a mass and it wasn't there before, go in and get it checked.
Go get
Not
checked.
say, oh, I had a normal mammogram, I'm not going to worry about it. 50% of all cancers come because women feel them themselves. So
Right.
this is, every woman has to be armed with this.
Yep.
And what we are daring to ask in this trial is like, maybe we should know more about everybody. Maybe we should know about the genes that you inherit.
Mhm.
Maybe,
Hello.
there are
You're
a
her
few-
story. You're her story. Your grandma.
Yes, that's right. And maybe you have inherited a set of mutations, that, and they're not that common. But a lot of people will say, oh, that's for the Jewish women. I'm African American. That doesn't apply to me.
Right, right. They
That
think
is not true. And so like the story of genetics is the story of population migration. I have a postdoctoral fellow from Trinidad, Kim Badal, who taught me that in the highest rates of mutation carriers, people inherit an error in a gene that makes their risk for breast cancer very high, like 80%. The highest rate of that is in the Bahamas. 20% of all women who are diagnosed have those genes. In
Sure.
Jamaica, it's like 1%. And these are in Black populations.
Right.
So it depends which families moved where. It's
Right.
not about you. Anyone could have those. And my colleague Fumi Alpade, who I know you've had on the show,
we love
thinks
them.
that maybe, there is a kind of mutation that is probably just as common in African American women as it is in Jewish women. And the only reason we know about it in Jewish women is because
we
they
tested
came
them.
forward and got tested, and
Yes.
because people went to the Tay-Sachs database and tested it. So we know about it. No, no participation, no representation. So this is the thing that and so honestly, when we started this trial, I said, look, we can do better. We can learn about those mutations. We can learn about there's a bunch of little genes that you inherit that by themselves don't mean anything, but together, many genes, polygenic risk can influence your risk up or down. So
Yeah.
now we're about 45,000 women in. And by the way, when I had gotten to about 15,000, I looked at it and we had like 2% African Americans on the trial. And I had the same message to everyone. It just wasn't resonating in the African American community. And I'm like, okay, this is unacceptable. We have to do something about it. I said, Fumi, are you going to help me or not? And we're obviously doing something wrong. And we are trying to get this message out. And again, no participation, no representation. The polygenic risk scores we know most about, we know in women of European ancestry because they're the ones that were in the trials.
They were in the trials, yeah.
We can't do this again. We just
Can't. We
do
have
it.
to fix it. We have to get more Black women in, and that's what.
And you want to know what I want to do next? Well, I mean, here's the other thing that we discovered. That of the women, so we have 22,000 women who've gotten their personalized risk profile done, right? And it turns out that of the people with mutation carriers, 2/3 of them don't have a first-degree family history of breast cancer in their mother or sister. So
That's
is
they're not necessarily in that high risk
Right,
category at all.
Right,
The
right.
classic
so
high risk
we
category,
should-
right? Mhm.
right. So the thing is, this test it's a spit test. It's
a
just
test.
a spit
Yep.
test,
But
right? To
people think-
participate, it comes in your mailbox. You open up the tube, spit in it, close the tube, stick it back in your mailbox. That's how hard it is. It is so easy. And this is nothing hard about this. This is information. Now,
Right.
you might get information you're surprised about, but forewarned is forearmed. It's not like you have to do anything particular, but you have information. It's not an emergency and you can make choices, right? And so that's why we want to get this information out to people. And, I'm looking at this data and I'm like, okay, if this is true, we're trying really hard to say, why don't we get this test done for women at age 30? And we could get that 2 to 3% of women who really are at high risk and screen them in their 30s, and then find the 50% or 60% of women who don't need to be screened till they're 50 or 60. The thing, and there's another thing too, is that, to this other article, because you have a higher risk of dying of breast cancer, you don't want to say, okay, just because I'm African American, then everyone's gets screened more. No, we want to screen the right people.
I was just going to ask you that, because
Yeah.
how do you juxtapose, the higher mortality rate and the increased risk and the not knowing the family history and the being more aware with a personalized approach that says maybe you would screen at an older age, and I think that how do we not conflate that messaging in the community? Because
Well, all right.
Yes.
Let's take an example. Get two women who come in, they're 41, Kim and Susie. You know, they would get the same recommendation today. Of course, that would depend on who they talk to. If they talk to the radiologist, they'd say, come in every year at 40, starting at 40. If they talk to their internist, they'd say, oh, come in every year, starting every other year, starting at 50. But actually both would be wrong, because Kim is a BRCA carrier and her mother died at 38. Okay, she should start screening at 30.
Right.
And she should be getting, if she's, you know, she could consider doing something to prevent getting that, or she should be getting high risk screening every 6 months. Whereas, you know, Susie has no risk factors whatsoever. She can start screening at 50. And it doesn't matter if you are Black or you're white or you're Asian or you're Latina. I could be wrong, but I don't think that just being Black is enough to decide that you should come in every year starting at 40 or 35. No more than being Jewish. I'm
No.
Jewish, you
I think
know?
it's why we need this data, so that women
Well,
can
yeah.
have confidence
Right,
that
and-
they don't need to
Exactly.
start at
And you know,
35 or 30.
I could be wrong, but I'm willing to put it to the test. And there are plenty of people who think that I'm wrong. Plenty of people think that I'm right. When people can't make up their minds, test it. And you know, it might not be just what I thought we were going to learn, but we're going to
You're
learn.
going to learn something. You're going to learn
We're going to
something.
start. And I want, what I want to do, just like with I Spy, I want to start changing every 2 years, try something new, start learning. You know,
Right.
there are problems to solve. We all, and you know, the thing
So
about it
much.
is that the radiologists aren't going to get up there and tell everyone to do it. I want women to say, please.
I want it. Give
do
it to
this.
me.
Right.
Let me participate. Let me, you're going to spend 35 years of your life doing screening from 40 to 75, right? How about just doing it in the trial and helping us drive change so that
About it.
10 years
you-
in, we have something better,
Mhm.
lots better.
And Dr. Mo, one of the things that's nice about wisdom too is that, and I know that there's that concern, what if I get, you know, less screening and I don't know if I'm ready for that? There's an option to be
Right.
on observation. So
Yeah.
you can still be part of the study
Mhm.
while following, you know, because I think it's pretty clear we're going to start getting some really specific data
Mhm.
on patients who are going to do better by having different schedules. And like the guidelines, I remember when they kept pushing the guidelines for screening up higher and higher, and we would have
Exactly.
panel discussions about why this shouldn't happen. And then, you know, they talk about the studies that showed that, you know, women really weren't really, you know, being identified or being
We're
diagnosed till later.
overdiagnosed with breast
European
cancer, right?
studies done years and years ago
Yeah.
were being used to make, you know, guidelines in that time, which was in the early 2000s, you know, and it was I was at Howard at that time, and we knew that the models that were being used, the Gale models, didn't reflect what was going on in African-American women.
So true.
We never used it. I remember being a fellow, and when I was a fellow, I was at Georgetown, and they were running one of these prevention studies, and I was sitting at the telephones answering and taking the data, and I thought, and I would calculate their risk and see if that they were appropriate for the study. And then once I just changed race, and the calculation went from a higher number to a lower number. And I kind of brought that up to someone, and no one could really tell, because no one really could tell me what the algorithm was. And that's when, for me, I stopped using that as a way of screening African-American women. And just kind of just by choice, you know, kind of got more conservative. And I said, if this is going to be inappropriate for my patient, I'm just going to start them as early as possible. And this is a way where you can find out specifically for that patient, because we're not all alike.
Well, let's talk. So we use the Breast Cancer Surveillance Consortium model, not the Gale model, because it represents 1 million women who reflect the population. That doesn't mean it's good enough for African-American women, but let me address this doing less business. You know, everybody thinks that there's this cultural mentality, especially with cancer, that more is better.
Little is good,
More is
more must
not-
be better. Yep.
No,
Not
more is
necessarily.
just more, and sometimes more is worse.
Yep.
You know, there's another side to the story. The 42,000 women that die, but there are 270,000 women that are diagnosed every year. And, you know, some of those cancers, there are some cancers that are really aggressive. There's some that are moderately growing, and there's some that are so slow, like prostate cancer. They're not going to kill you. And now you would say, oh, why is it bad to do more? If you had a mastectomy and then you have a complication, or you feel horrible about it, and you had a cancer that wasn't going to kill you and really shouldn't have been called cancer, how are we helping you?
Right.
Overdiagnosis has a face. I can't, getting called back for a biopsy isn't that benign either. Someone called me last week that, oh my God, I've got metastatic disease everywhere. I can't come in. And I'm like, I had to talk her off the ledge. I said, I don't even think this is very risky. Like I'm on the, I don't, and people do that twice. They're not going to come in. A woman who screens every year for 10 years, especially in their 40s, their chance of getting a call back like that is 50%. It's not benign, and it's not benign. It's not good to tell people they have cancer when they don't. And let's talk about this epidemic of DCIS. We found 70,000 cases of DCIS a year. And if all those were destined for cancer or to invasive cancer, which after 10 years, the invasive cancer rate should go down, but it's not. It continues to go up. You have to say the math doesn't work out. Something is wrong. So that's why we started this. I'm starting this study called Recast DCIS. We're looking at the conditions to find out what's suitable to make it active surveillance. And it turns out that some people have lesions that are risky and some people don't. And probably about 60% of people don't need surgery. But it's not like, oh, I can randomize it and you might or you might. Let's learn. So we're doing the same thing I'm doing in iSpy. Get the MRIs, figure out who's got the focal lesions. I've been running this active surveillance study for a long time. People are coming out of the woodwork to ask me to be in the study. And we're starting a big national study that we're going to open up in September. And we're working on vaccines. We're working on new things. It is like, if you have DCIS, that's pre-cancer. It's not an invasive cancer. You got plenty of time to sort it out. No one's life is threatened there. But there are things that we can do that are different. And we've been treating this the same as if people have cancer. This is not good. We actually radiate people who don't need it. We're still radiating people with DCIS, but in fact, we're not even radiating people with invasive cancer who have it. Don't be in a big rush. Cancer is an emergency because you know about it. You do not need to be in a rush. This is not like leukemia where you have to make a decision in a week or two. You need to get your information figured out. You have time to get a second opinion. These are important things to know. Your health is on the line.
Precisely. This is exactly what I tell patients. You have time. There's no hourglass hanging over your head for this, and you need to make good choices. You need to build good relationships. You need to understand what's going on and what your options are. And there's this hysteria that happens, and we understand why. We do. We know what we've seen. We know what we've experienced, but we have to balance that out. So this is huge. We've got some folks in the chat who are talking about this. They want to know how to get involved and how to help and what can people do? How can they support this movement? Because we've got some folks who are working in healthcare, advanced practitioners and
Nurse
others.
practitioners,
They're asking for
the great thing about wisdom is anyone who has not had a diagnosis of breast cancer, who's between the age of 40 and 75 can go to wisdomstudy.org and sign up. That's it.
It's in the chat. I put it in there. Wisdomstudy.org is in the comments. Go sign up. Go sign up.
Right. And people need to understand this is mobile. I mean, everything in Wisdom Study that is you don't have to go into an institution and take time. This is done by you, the patient. So
the only thing we ask is if you join, stay connected.
Yeah.
And we need one piece of information. If you've had a mammogram, get us that piece of information about your breast density. We teach you how to do it with a little video, that's in the where you sign up, and just answer our questions once a year. That's really all you need to do, and you can be part of the movement that changes the health of women. I like to say we're on a mission to celebrate more birthdays. So
I love it. Yeah. And if you have questions, you can always email me. You guys know how to reach me. And if you go to whenwetrial.org, we can connect you to the Wisdom Study. So it's all here, but Wisdom Study.
And if you have cancer, You can go to breastcancertrials.org.
And that's on our When We Trial website. If you go to whenwetrials.org.
And you can
Yeah.
ask your physician, I am interested in clinical trials.
Yes.
What am I
An
eligible?
option for me? What's an option for me? And you know, you guys, it's so funny because my first mammogram when I was 40, I had calcium deposits on my breasts, and I had, you know, my little fake, my fake ones are the ones trying to kill me. But they ended up having to biopsy them because they took them out, but they never, ever warned me. And I was at one of the best cancer centers in Atlanta. They never told me I was at risk for cancer. They said, oh, we're going to take care
So
of
there's
this.
something, so that's why I say screening should be integrated with prevention. One of the things about the wisdom study is
Right,
if you were in that high risk group, we call you and we talk to
Right,
you and
and talk-
educate
yeah,
you
no,
about your options. You know, if you look at
No, we do.
cardiology, you know, when I started, your chance of dying of heart disease was twice as high as your chance of dying of cancer. That's no longer true. Now it's higher for cancer. So how did they do that? They went about it in a systematic way. 1945 started the Framingham study. They figured out what the risk factors were. Then they tried to figure out what are the indicators of risk and how can I change them? Cholesterol, blood pressure, like,
Right.
you know, we can do that too. I'm like, I'm not going to let the cardiologist have like all the success. We can do this.
I know,
This is
I
about
know.
your life, but we can't do it unless we get started. It's a
And
long
we
journey.
talk about it. We have to talk about it. We're not talking about it with our moms and our sisters and our aunties.
And prevention has to be on the table.
Yes.
I mean, Sarah, don't you agree with this? It's like, no, people say, oh, we can't study or we can't do it. But you know what? There are imaging tools that we can use to find out, are you at risk? Are you going to get better? Can we
Right.
make that risk lower? We can do it now. We have to make it a science that people want to go into and change it. I don't accept it that we can't do better.
Yeah, and Dr. Mo, you asked a while ago about how do we get to getting providers and so, you know, one of the things we're going to start doing, and we're working on this now, is targeting residents, you know, because in my experience, that's when they're at the most
Absolutely.
ready
They're hungry.
to go into, you know, they're seeing
Right.
patients already. And so we are kind of working on putting together kind of a curriculum that hopefully is going to involve some of the I-SPY investigators helping to go to some of, for me, I'm targeting HBCUs or institutions, so that they can see providers who look like them, they could understand what a clinical trial is. And then, of course, this is breast cancer focused, so we're going to use breastcancertrials.org, show them how to use it.
Right,
You know, we all
right.
know clinicaltrials.gov is out there, but
That's
no,
a horrible place.
and it's horrible and
bad.
it's hard to use and you just kind of go and fumble. But breastcancertrials.org is like beautiful. It's so intuitive.
Beautiful, yeah.
Put that in the chat for sure.
I'm putting it in. Yep. And it's on whenwetrial.org.
And once you show someone how to do it, you know how that is. You've seen it. You just go and start using it. So
That's awesome. I love that idea because the residents are really, it's where the most transformative part of your practice, where you get that foundation, where you get hungry, where you realize that you can have a clinical practice that incorporates both research and, you know, your clinical volume. And you need to be asking these questions, and it's important to do it from the inception, you know, so that's fantastic.
yeah, thank you.
We have a lot of work to do, ladies, but you know, I don't think anyone's going to rain on our parade.
No one's going to rain on your parade, Ricky.
No one's going to
That's
rain
right.
on our parade. We're going to make it happen. But it starts with education. And
It's
I
everything.
find that when we talk to our breasties, they're so afraid. And the fear is because they don't know. I mean, if you think about, if you don't know something, you're afraid until somebody teaches you, right? And then all of a sudden, you know, I'm afraid to cross the street. I'm afraid to jump in the pool. But all of a sudden you learn to look both ways and cross street, and you're cool with it. You learn to breathe underwater and you can swim. It's fear. So we have to educate them and say, this is how it works. This is the basics. This is how we're going to take care of you. And this care is for you. And once you understand that, you can jump in. I learned in our research that I could convince someone to go from a 1, I'll never do a trial, to 5, sign me up, in 5 minutes.
Are there
By
patient
explaining it.
stories from I-SPY and from
Yeah.
Wisdom? Are there patient
Oh, yeah, we have,
that we can refer to?
oh, yeah. So if you go to the ispy2.org website, there's like all these patient testimonies. We have this amazing, the iSpy2 patient website is amazing. And all these testimonials, you know, I want to just say something about fear in cancer. Everyone who's diagnosed or hears those 3 words, you have
Right.
cancer. Everyone is
Yeah.
overwhelmed with fear, and it's such a terrible
Mhm.
time. You feel like you've got hit by a truck.
Right, Chuck.
But everybody needs to know, breathe, step back. Don't rush to make a decision. Your life is not on the line in that week. It's you have the time to sort of hear those words, and you might have a really nasty cancer, but you might also have a really indolent cancer. You want to make sure that you don't get overtreated, which is pretty terrible too. And you want to be sure that you get the right treatment, not just treatment because
Right.
you're afraid. And everyone needs to know that they're not going to always feel the way they feel the day they're diagnosed.
Right.
Like when someone says, oh, it's not uncommon, someone say, I want a bilateral mastectomy. I'm like, okay,
Breathe.
that's fine. What is it that you're hoping to accomplish?
Yep.
Well, I want to save my life. And I said, well, what if I told you that it's not going to make a difference in whether you live or die? Really? People just don't know because it seems so, because I think you have this visceral reaction, it's just, oh my God, my body has turned on me. These breasts that were supposed to like feed my children or do something are now going to kill me. Get them out. But that isn't necessarily going to help you. And I know it's hard. That's why in the I-SPY trial, the idea that you start with the systemic treatment or the whole body treatment first seems so weird. Just get it off. And I'll say, well, look, we need to know that we've got the right drug, because if we make the right drug go away, the amount of surgery you need is a whole lot
Right.
less.
Well,
Right.
and it may
I'm-
impact the risk of recurrence, because that's
That's
what drives a
it.
lot of fear, especially for Black women. The
Yeah.
42%, you hear there's a 40% higher risk of recurrence for your cancer. You're thinking, do everything.
Do
and
everything, take it
that-
off.
But don't do things that don't matter. And if the tumor
Exactly, that
goes
don't
away,
matter.
your
Yep.
risk is down to 5%. Okay, if the tumor is still there, you need to do more.
Mhm.
That's how we know.
That's how we learn.
And it's like, it's a change, and trying to get people to change is hard. As I said, everyone's fine with the new iPhone, but they're not fine with their care changing quickly. But they should be even more anxious to see new changes and demand more.
Right.
It is, but knowledge is the antidote to fear. Now, to the person who's on the internet reading every absolute thing, sometimes
That's
you-
not,
that
that's not
doesn't,
knowledge.
that does also doesn't make your.
No, that's not
your-
knowledge.
But I think the other thing too is everybody has risk.
Yeah.
Yet we get in our car, we walk across the street. I was texting angrily the other day and tripped on the train tracks and sprained my ankle, so like, so like there are plenty of risks we take every day, so just take a step back. This is a risk that don't let fear drive your decisions. Get educated.
That's a huge take home
It's
here
your
today.
body, your choice.
Don't
You're-
let fear drive your decision making.
Don't
That's
let
right.
fear, don't be overwhelmed with fear. Take a breath, take a week. I never operate and do a big surgery on somebody within a week of their diagnosis.
Oh,
Because
no.
if you wait 2 weeks, people have changed their minds.
Mhm.
And, the other thing, people have time to think about it during the time of their systemic therapy. And maybe you've got an inherited risk, and maybe your risk has gone away from this cancer, but now you've got a big risk because it might happen again. You have time to make those choices.
Yeah.
Get all that information. That's the way to go about it.
Right.
And we can help you. We can help you. Take
Yeah.
a breath and call us. Reach out
Get
to
another
us.
pair of ears, get somebody
Yeah,
to
we'll
take
help
notes.
you. We'll talk you through it. We'll call we'll call Dr. We'll call
Absolutely.
Dr. Or we'll call, I will. If you know me, I will pick up the phone and text the doctor and say,
1
help me.
a.m. That's right.
Yeah,
And that's
any
what we're
time of the
here
day or
for,
night.
though. Absolutely.
Yeah, so.
Sometimes
but
you
Are
gotta
there
make
men?
it
Are there
work.
men in any of these trials? Someone in the chat had a really great comment.
Yes,
Men
I
with breast
I-SPY,
cancer too.
I-SPY is open to men. Men don't usually get DCIS because we don't screen them. The risk for breast cancer for men is 1 in 100-fold less. If you're a carrier, if you're a mutation carrier, it's 10 times higher, but it's still 10-fold less than it is for women. So it doesn't make sense to screen. But again, every woman who has a mutation has inherited that risk that increases their chance of getting a cancer. All the men in their life
Yeah,
know about it. and men can
right.
carry it. So what do you need to know? I actually have the choice about whether or not I want to pass that gene down. If I have this gene and I might decide I want to have my embryos tested, so I get the gene that doesn't have BRCA mutation in it to my child. You don't have to do that, but that's a choice. And they better not try and take that away. And so, but we better fight like hell to keep it there. So these are choices. These
Yeah.
are, and there are other cancers that you might be at risk for. These are things that you can know. And we also know, remember that polygenic risk, that can affect how much risk you have from your mutation.
Indeed, that's
The
right.
Yeah.
more we study it, the
Yep.
more we know. And by the way, there are specific drugs coming down the pike that will be effective, that we are going to
Application
test
for
and
treatment.
identify, in
Right.
which case it might be prophylactic mastectomy is not needed because we've got the exact treatment that might take a month and you'll be fine.
Yeah.
That's the goal. So don't be afraid. Don't say, oh, I can't know. It's too scary to know. It's actually too scary not to know.
Not to know. Not to
Wow.
And the more we know, especially about these mutations, because I know my patients would get the mutate, when we test for BRCA, they'd have variant of unknown significance.
Mhm.
So many of them, they're unknown significance because no one's really kind of
No one's
studied
ever
them
studied
yet.
it.
And once you get that critical mass, it may become significant, but we won't know unless we test ourselves.
Yeah. Somebody's asking how accurate are BRCA testing results?
They are, okay, so they are very accurate if you have it. Now, that doesn't mean we know every genetic factor. You can have family history and not find something that drives it. That doesn't mean that it's wrong to do the BRCA testing. That just means that the more we do that, the more we're going to find out. Right? So that's,
Oh,
but
I
the
mean,
gene
right.
tests are very, very accurate
Right.
now. The
yeah.
sequencing is very good.
It will be interesting to really elucidate whether or not the rates of BRCA mutations in younger women are truly the same as the rates for the postmenopausal population, or whether there's increased rates, especially in Black women, and I don't know that we don't
look at
necessarily have
that.
the answer for
No,
that.
again, until you study it, you don't know,
Right.
but in
The
the
question,
hallmark of people with these inherited mutations, especially BRCA1 and
Mm.
PALB2, that's shifted so that people are at risk in their early 30s.
Right.
So that's important to know. But in the wisdom study, we found people who find out about it when they're 55. But that's important then. Maybe that already tells you something that they've gotten to 55
Right.
without having had a
Right.
cancer. And so, all those things are discussion. Don't be, again, don't be pushed into one thing or another. All this stuff,
ask the question,
ask the question. Exactly.
do the homework and ask for help.
There are more genes in BRCA, and I think that we really, really need to highlight that for the community as well.
Yeah, we
because a
haven't found
number
the
of
Black
folks
ones yet.
who have gotten tested for BRCA.
Oh, be
I
careful.
remember, right? I got tested back in 2014. My mother died of ovarian cancer. My grandmother had bilateral breast cancer. There's update testing. There's panels. There are more genes that we
Yeah.
need to study. And those people who only got tested for 1 and 2, yes, you are eligible. There's still more information
Yeah,
that
so
we
there
need
are
to
9
know.
genes, 9 genes now that are
Yeah.
associated with inherited risk for breast cancer that we understand.
Yeah.
That's what we use in the wisdom study, plus
Exactly.
all that background risk.
Right.
Exactly.
Whoa, you guys.
Wow. This is awesome.
It was a
Thank
great afternoon. I got to go back to clinic.
Go back to clinic
Thank
and
you
save
so
some
very
patients.
much.
Thank you so much. We got to do this again. You guys, if you have questions, email me. I'll hook you up with these amazing doctors, and
Yeah, the links are in the chat.
the
So
links
we
are all
want
in
you to
in the comments. Yeah.
go to the wisdom study, go to I Spy, read
Yeah.
about it, ask somebody, ask questions, email us, give us
Follow
feedback.
us.
Because
Yeah.
we want to
Ask your
continue this dialogue.
doctor.
That's
Ask your
right.
doctor. Ask your doctor. And if you need a doctor, we'll get you to one of these.
We'll find
brilliant-
you one. Absolutely.
Yeah.
Spread the word, please.
Spread
Yeah.
the word. Get us more sign. Get more Black women doing this research. We need our bodies.
Please.
Please.
That's right.
Big
Help
out
us
there.
help
More of
you.
us as PIs in the community,
I
more
want-
community docs. Yes.
Right. I want this trial. I want women to say, this is my trial. This is
Yeah.
how I learn. And, there's an amazing, go to Time Magazine. They did a series of, which Ricky started in, these amazing videos. But the
Mhm.
stories of women, someone just saying, wow, I didn't have high breast cancer risk. I thought I did, but I saw that each year that I filled out that survey, I was checking off more of the boxes that made me feel unhealthy, that I realized I needed to get a hold of my health. And it made her like lose my
Hey.
they got rid of her diabetes. It's just like, so I'm like, okay, wow, that's fantastic. Getting people engaged and involved in their own care, that is the ticket.
Yep. Tell your mama, tell your sister, tell your auntie,
Mhm.
tell your hair salon, tell your stylist, tell your nail person, talk about it.
Tell your story. Don't
Tell
go
your
through your breast
story.
cancer journey alone. Don't not
Yeah,
tell your
tell your
family.
story.
And
There's
share
a way
your
to have
wisdom
those
by joining wisdom.
conversations.
Yeah.
Share your wisdom. I
Wisdom.
love it. There it
Okay.
is. That's the
Yes.
tagline
love
for
it.
today.
Yep,
Share
share
your
your
wisdom.
wisdom.
Wow.
Thank you, ladies. Thank you,
Mhm.
doctors.
Thank you so
Love
much.
you.
We
Thank
hope
you
this
for
has
being
been
partners with us. Thank you for
Yep.
partnering with us in this work. We so appreciate you.
true.
Thank
We
you,
hope
Nancy.
it's
Thank
been
you,
relatable,
Benedict.
Okay,
reliable, and real.
bye.
Yep. The
All
doctor's
right,
in.
ladies, thank you again.
Thank you so
Take
much for
care.
having us.
Rusty love.
Rusty
Bye.
love.
Bye.
Bye. Did I have to ask? Did I need to ask you something?